CDK4/6 inhibitors have demonstrated important improvements for women with ER-positive, HER2-negative breast cancer. First, we had second-line studies, then we had first-line studies, but never a comparison between both. Nevertheless, a first-line strategy was adopted by most guidelines as the preferred strategy. These agents, however, have toxicity, considerable costs, and there are mechanisms of resistance occurring when you have combination therapy. Therefore, also inspired by ESMO's and ASCO's commitment to stimulate equitable and sustainable healthcare, we set up the SONIA trial to have a one-to-one comparison between a first-line strategy and a second-line strategy. All patients were randomized one-to-one for either of those strategies in a backbone endocrine therapy, which was similar for all patients. So they got an aromatase inhibitor in first line and fulvestrant in second line. Primary endpoint was progression-free survival after 2 lines of therapy. I can continue if you want, I just talk on. Yes. 1,050 patients were randomized. Response was measured locally according to RECIST 1.1. And key secondary endpoints were overall survival and quality of life. At the data cutoff, December 1st, 2022, we had sufficient events, PFS2 events, to do the primary analysis. What we saw was first a confirmation that in first-line treatment, CDK4/6 inhibitors prolong progression-free survival. However, if all patients cross over to a second line, the benefit disappears, and progression-free survival after 2 lines of therapy almost overlap. The hazard ratio for our primary endpoint was 0.87 and not statistically significant. Overall survival was also measured at 35% data maturity, and the hazard ratio was 0.98, p-value of 0.83. Importantly, however, toxicity was increased in the first-line use owing to the fact that you have a longer duration of treatment by almost 16.5 months. We also measured quality of life according to validated questionnaires, FACT-B, EQ-5D, at several time points along the study. There was no difference in quality of life between the arms. So we conclude that the first-line strategy does not give a better progression-free survival, it does not give a better overall survival, and it does not improve your quality of life. However, toxicity is increased, quality of life is not better, and the costs are dramatically higher at $200,000 per patient. So we think that the SONIA results seriously challenge the paradigm that first-line use is the standard. And we think that endocrine single agent in patients with metastatic ER-positive, HER2-negative breast cancer is an excellent option. Of course, we'd like to see which patient benefits most from either strategy, and biomarkers should be able to tell us. Until now, however, biomarker search in the CDK4/6 space has been rather disappointing, and we have to make patient decisions today. Again, the SONIA results favor a second-line strategy with CDK4/6 inhibitors.